they know they see her for market.
Our next presenter is going to be a person that has been very, very concerned with children, adults, and teenagers. She is no other person than the erudite Dr. Justina Nkechi Olajide. She's a consultant family physician. She is also the chairperson of the FMC Asaba Nutrition Steering Committee. Please give it up for her as she mounts the stage. Thank you so much.
Good morning, everybody. Standing on the existing protocol, I want to appreciate each and every one of us, and I want to ask us to give apt attention to the topic before us. A lot has been said concerning nutrition, and so some slides will be skipped because of time. Some of us will be traveling today to catch up with their flights and all that. So where we have nutrition, and they are almost the same thing, we'll skip that. The topic is on nutrition, immunity, and malaria in an endemic area. Nigeria is an endemic area, and in fact Nigeria has the highest burden of malaria in the world, and south in Nigeria has the highest. And so as you're sitting down there, mosquitoes might be biting you on your legs or wherever, and then you see people clapping their ears and all that. Now the mosquitoes are very intelligent. If they go to the mortuary, they make their buzzing sound and nothing happens, and they leave because there's no blood. But you that you are alive, when you hear the sound, you want to quickly catch it and kill it and all that, then you know that there's blood in here. And also the smell, it has a very strong perception, so it can get blood. So the topic, like I've said, is on the board. So nutrition by definition is the process through which the body acquires and utilizes nutrients for necessary growth, maintenance, immune competence, and resistance to infection. When you have nutrition, it helps in growth and development, recovery, healing. All this has been done. When people are on admission, when they are well nourished, they are discharged on time and they go home. And then they have physiological resilience. When there is nutrition is a clinical determinant, not only a dietary issue. Nutrition shapes the body's capacity to resist, to fight, and to recover from infections. In malaria endemic settings, the child's nutritional status is a clinical significance as the parasite itself. So what we are saying is that a child has malaria infection. You don't just face only treating the malaria, you also look at the nutritional status, because if you don't take care of that, you might be wasting your time, because the malaria can end up killing the child. How nutritional deficits affect infection risk discovery and clinical outcomes. We saw in some studies that stunting was about 30.9% in this clinic population. Wasting was all that. We saw that in presentation yesterday. And then vitamin A, about 190 million children globally are affected by vitamin A deficiency and all that, to draw us back to the impact and the outcome of all this is impaired innate defenses. Then there's reduced recovery capacity and worsened clinical outcomes that will lead to severity and impaired response to antimicrobial treatment. So now nutrition and immunity, how nutritional status shapes the body's defense against infection. So the immunity helps you to fight against those viral infections, bacterial infections, and all that. So what is immunity now? By definition, is the body's ability to resist and eliminate infectious agents through coordinated innate and adaptive defense mechanism. The innate mechanisms are the ones that come first. They are the ones that you are born with. You come down with it. So they are non-specific. They work everywhere, and immediately they respond to whatever infections that is there. So we have the physical barriers, the skin, the mucosal epithelium. We have undercellular macrophages, neutrophils, natural killer cells. Then you have the cytokines, tumor necrosis, alpha, then interferon gamma, interleukin 12. Also, you have fever response as a defense mechanisms, and you also have they are first to encounter Plasmodium parasites. While you have the adaptive immunity, which are acquired. For example, we are living in Nigeria, and so mosquitoes have been biting us. So our body has developed immunity to fight those malaria infections. But somebody living in America and somebody living in the Arctic or Antarctica areas where there is no malaria, they don't have adaptive immunity, and so if mosquito bites them, it can even kill them. In the past, we discovered that people died of mosquito bite, and they said a small tiny mosquito killed some persons, and we all heard it. Is there anybody who heard that? Yes. So what happened is that you have adapted to it and you have developed immunity. So this immunity that is acquired are specific. They are slower, but they are more targeted, and they come within days and weeks. We have the T lymphocytes, they are the cellular immunity. We have the B lymphocytes, they are antibody productions, and then we have the immunological memory after exposure. Clinical immunity to malaria develops with repeated exposures. This requires intact nutritional status to function effectively. So specific nutrient immune function relationships. The protein, what does it do? Generally, all the functions. Then when there is a protein energy malnutrition, they are reduced. Vitamin A, what do they do? Mucosal epithelial integrity, T helper cells differentiation, natural killer cells activities, and then now vitamin A deficiency will lead to what? Impaired clinical immunity to malaria. Then you have zinc, and what does it do? Immune signaling, that's what it does. And you see the natural killer cells, cytotoxicity, then interferon gamma production, oxidation burst, killing of the parasite. That's what zinc will do. And then Plasmodium steals zinc from the host when you are not well nourished to produce and to have enough zinc in the body. Then the iron, what does it do? Hematological function, erythropoiesis, zinc helps production of red cells in the body. And then when there is no zinc, what happens? There is an iron paradox in malaria. If a child is having malaria and then you just treat malaria and you don't treat the iron, and you don't give iron to the child, there is a paradox. The reason is that the iron is a nidus for infection, and so the malaria parasite now takes out of it. And so when you're giving malaria, some mothers, every morning they bathe the child, they give iron. Every month they bathe the child, they give the iron. Even when the child is sick, is having malaria, they don't know. They are just giving iron. So they are not treating for malaria, but they are giving iron. It's very dangerous. So if you are in an endemic setting where you know that there will be malaria infection, then you treat for the malaria while giving iron. So nutritional status and immune response, two pathways, adequate versus poor nutrition. When there is adequate nutrition, what happens? There is functional immune response, which leads to effective pathogen control and better clinical outcomes and faster recovery. The person, there is a reduced severity. But when there is poor nutrition, the person does not eat well. His immune systems are dysfunctioned. There is increased susceptibility to infection. It has higher infection frequency. the disease will now progress and there will be an increased morbidity and mortality. Next slide. All right, so malaria, mosquito. You can see the mosquito there. I've already introduced it when we are talking about malaria. Applying the nutrition immunity framework to Plasmodium falciparum malaria. We are talking about Plasmodium falciparum malaria because this is an endemic region, and Plasmodium falciparum is the most dangerous because it affects both the young blood cells and the mature blood cells. We have other species that affect only the young blood cells, and we have other ones affect only the matured one, but this one affects both. So now look at the world malaria map. We have those areas that are blue. There are no malaria there. So and those areas, we are looking at Russia, we are looking at Australia, we are looking at, when you come to America, North America, and then we are looking at Chile down there. But that side where Kevin went, Brazil, there are malaria infection there. Where Kevin went to get all those nutrition for us. I remember. So there are malaria infection there, but they are not always. Look at the color there. The blue says malaria transmission is not known to occur in these blue areas. You have the Arctic up north and the Antarctica down. You have Australia there. You have Russia. You have North America, and then you have this Chile. But then the yellow is that malaria transmission occurs in some places, not always. But look at the red. What did they say? Can everybody corrose it? Throughout. And that is why we put mosquito net on our windows. Maybe the net is not enough, so you have to sleep under the net in the bed because mosquito is there throughout. It's either you have waterlogged areas, or you have a stream somewhere, or you have 30 places where they pack things near your house, or the rainy season, mosquitoes are there. So looking at malaria in endemic settings, malaria is a major infectious disease with variable outcomes. And these are the outcomes which we have 269 million people affected by malaria globally in the year. And then we have 597,000 deaths. We have over 90% deaths in Africa. And in Nigeria, we have 27%, which shares the large chunk of it. So most factors that influence malaria disease program have nutritional status. If the person is not well nourished, and a little mosquito, we get two children, one is well nourished and the other one is not. And so you allow mosquitoes to bite them. The one that is well nourished might not come down with clinical malaria, but the one that is not will come down. So nutrition plays a very important role. Then immune response, both the innate and the adaptive mechanisms working together, you will see that that one also affects. Then the age, we have told us that the under 5 and the elderly, according to age, have the highest risk. So then previous exposures, prior malaria exposed episodes should give you partial immunity. But those who have never been bitten by malaria, pity them. God will help them. Alright, next slide please. So the same thing now coming to Nigeria itself. 27% of all global malaria cases will said that 185,000 malaria deaths annually in Nigeria. It is predominantly pediatric age groups and pregnant women, then the elderly. Then highest transmission in South and Nigeria and Northeast. Then the cases are rising post-COVID. We had about 68 million people that had malaria in 2022. So Nigeria under nutrition, stunting was all this in the next slide. So beyond under 5, school-age children and adolescents are equally affected by malaria infection. But a point of note, school-age children between 6 and 11 years, we have that they develop clinical immunity, and so asymptomatic malaria is common. For example, now if you ask majority of us sitting down here, it's like we don't have malaria, we look fine, we are well. But if I collect your blood samples here now, I will see people with 2 pluses, 1 pluses, some people even 3 pluses. So they are asymptomatic, but they have malaria parasite. Next slide, please. All right, the cascade from plasmodium infection to clinical outcomes. Nutritional activities. What does it do? When there's adequate protein, there's a robust innate response. We've seen all this in the past. Plasmodium falciparum infection. What does it do? It acts on the innate immune activation and tries to reduce their activities. Macrophages, natural killer cells, cytokines, coming down to inflammatory response, the fever. And that is why, whenever a child comes to the hospital, you want to check, you have malaria, what do you do? Please, can anybody answer? What do you do when you see a child come to the hospital? You want to check whether that child has malaria. Can somebody just signal what they do? Yes. You touch, yes. CO Africa, kudos. You touch. You want to know, is there fever? Then I want to point out something to us, that the child that is well nourished, that can mount up immune response, will not be able to have fever. But those children that are very sick, severely sick, they have malaria, but they cannot mount up immune response. So you will see them. That was what prompted me to go into one of the studies I did. When I saw the children came in looking very weak, apathic, but their body is not hot. Because the one that the body is hot, the nurse will shout, doctor, please, this one's temperature is 38 degrees. I will give paracetamol, please give. But this one is very calm and does not have any fever. By the time we take the child to the lab, we discover the child has malaria parasite, 3 pluses. So the thing is that they have not been able to mount immune response because they are not eating well, they are not well nourished. Next slide, please. Pathway, poor nutrition that worsens malaria outcomes, and the other way around, malaria infection that leads to nutritional deterioration. So when a child is not properly nourished, poor nutritional status, it leads to reduced immune competence. And when the immune competence is reduced, there's altered parasite control. The parasite begin to grow because there's nothing to hinder it. And what does it do? It leads to increased malaria morbidity and mortality. On the other way around, a child has malaria infection. The child now has inflammation and increased metabolic demands. The body now needs a lot of food, nutrients, and then he now has reduced intake. He has nausea and vomiting. He cannot eat well. What does it lead to? Nutritional deterioration, and eventually it does what leads to undernutrition and what? Reduced immune reverse. Next slide, please. So the mechanisms and nutrition and malaria immunity, how undernutrition disarms the child's defense against Plasmodium falciparum. Let's go. So that's the Plasmodium falciparum infection at the center there, when there are reduced protein energy malnutrition, reduced activities of zinc deficiency. When there's zinc deficiency, what does it do? It reduces all the cytokines and all that. Then vitamin A deficiency also leading to reduced immunity and so on, and iron deficiency. Next slide. So vitamin A deficiency and malaria, all those are what we are saying. So and we have said it, that standard vitamin A deficiency test underestimates deficiency in endemic areas. So let's always do our screening to find out all these other ones. So these are work that are done. The landmark of randomized control trial in Burkina Faso, and this was what they found, that vitamin A plus zinc versus placebo will give 34% reduction in malaria prevention, and then a significant reduction in fever episodes and reduced malaria anemia. The other work also done also revealed that zinc supplementation in children less than 5 will reduce incidence of clinical malaria, reduce malaria-associated diarrhea, and then they work synergistically with vitamin A. This was done by Borke et al. 2024. So the take home there is that when you're treating malaria, also give all these other vitamins. The iron paradox that we've talked about, that you don't give iron alone. So there was a work that was done by the Pemba trial. What did they do in Tanzania? There was a randomized control trial of routine iron and folic acid in children in high malaria setting without giving malaria treatment. And what happened? There was an increased risk of hospital admission, increased mortality, especially from malaria. Then this trial was stopped very early by the Data and Safety Monitoring Board. And then the WHO subsequently revised iron supplementation guidelines for endemic settings. They ruled that iron must always accompany malaria treatment or prevention and never stand alone. Okay, malaria as a driver of nutritional deterioration, the reverse pathway, how malaria makes malnutrition worse. We've seen that before. Can we move? So we can just see anorexia and metabolic stress, which have been discussed earlier. Then there's growth flattery and being faltering, micronutrient depletion, and then the cumulative cycles. They are telling me that I have 3 more minutes. Please, next slide. Alright, so having known all this knowledge, what do we do? Integrated interventions. Go on, next slide. So there were some work that was done by the 3 different groups. We have seasonal malaria chemopreventive alone as control. Then seasonal malaria chemopreventive with vitamin C. It enhances immunity and reduces malaria. With vitamin C and zinc, there was a synergistic effect and malaria was reduced drastically. And then look at this. Seasonal malaria chemopreventive and lipid-based nutrition supplements reduce malaria drastically. So when we are giving, I was very happy on that Monday when they brought the table and there was palm oil there. There was some other oil that you could use. So when you're making and mixing the food for the children, please let there be oil in the food, lipid-based. Next slide, please. WHO said post-discharge malaria chemopreventive should be done regularly because about 30% reduction in hospital readmission is when you go and do follow-up. So we have ready-to-use therapeutic foods that are given with lipid-based nutrition supplements. Then we have dietary counseling, which has been stressed by the first presenter. They even go ahead to the community, micronutrient supplements, and then regular follow-up. Next slide. So clinical nutrition implications. Next slide. Nutritional screening should be done regularly whenever the children come. So, and then early identification of the risk should also be taken. Nutritional support during the illness and recovery focused care should be given. We have dietitians doing their work and growth monitoring. Next slide. Multidisciplinary clinical nutrition approach. All the different professions should come together to collaborate to care for the patient. Next slide. So I think this is the conclusion. Integrating nutrition into infectious disease programs, like the first speaker spoke, that they should also give them food. As you're giving them treatment, you also bring food for them. So I don't know who is going to do that, because I don't have food to give to my children. Give them, and then we have packaged food, and then community-based screening, like I said. Then we have affordable nutrition interventions, digital and mobile health innovation. Please let me just talk a little on birth order and family size as screening triggers. Some work was done. I did some of the work and discovered that the larger the number of people in the family, the more they come down with malaria. The reason is that you see many people sleeping in a room. One mosquito bites one, goes to the other one, goes to the other one, and spreads. So the more the number of people in the family, the more the mosquito. And also the birth order is also related to malaria. The reason is that when you have like 1 or 2, you can really take care of them. But when you have 7, you have 12, you just cannot do what the other one is doing. Next slide. So take home, nutrition provides the foundation for immune function. Immunity determines the host response to malaria infection. Clinical nutrition has a role in improving malaria outcomes in endemic settings. Malaria actively worsens nutritional status. Iron supplementation alone is a patient safety risk in endemic settings. Next slide. So these are my references. And the next slide. Thank you.
A good woman is a blessing from above. Her type will not there for marketing.